Welcome back guys. Now in this video let's discuss about molar pregnancy. Now first thing first, molar pregnancy is a condition which is benign in nature. Okay, it's not a malignant condition, it's a benign condition. Now what exactly is happening in this molar pregnancy? Now please concentrate guys. Actually when sperm meets ovum, okay, whenever there is the fertilization of ovum by sperm, now we all know that this embryo is going to divide and it forms inner cell mass and outer trophoblast. Actually inner cell mass is the one which forms the baby. Okay, inner cell mass is the one which forms the baby and the trophoblast is the one which forms the placenta. Now in this condition of molar pregnancy, what exactly happens is abnormal proliferation of the trophoblast. Trophoblast is abnormally getting proliferated and doesn't allowing baby to grow. Okay, it's outcrowding. The trophoblast is too much developing and it's not allowing the fetus to grow. Okay, that's what exactly happens in the molar pregnancy. So what is the definition guys? It's the abnormal proliferation of the trophoblastic tissue. Okay, now see this molar pregnancy, I have already said you it's a benign condition. And how many types of molar pregnancy are there? Partial mole and complete mole. Okay, now itself I am saying out of these two conditions, the bad guy is complete mole. Okay, when compared to the partial mole, complete mole is a bad guy. Why? Because all the clinical features, whatever we are going to discuss, they will be markedly seen with the complete mole when compared to the partial mole. Okay, now having said that, first let's talk about the partial mole. What exactly is this partial mole? Guys, please see and why this happens. Normally, what should happen? A sperm should meet the ovum. A sperm will be having 23 chromosomes and the ovum will be having 23 chromosomes, so that whenever the fusion happens, the embryo will be having a diploid state, that is the 46 chromosomes. That usually happens. But here in this condition of partial mole, it's a triploidy state. Okay, that's the MCQ. It's a triploidy condition where you are going to see a 69 chromosomes in the resulting product. Okay, after fertilization, whatever the product is there, you're going to see 69 chromosomes over there. Okay, it's a triploidy state. Now, why this karyotypic abnormality happens? It's because, see, there is no problem with the ovum. 23 chromosomes are there, okay, 23X. But this ovum is getting fertilized by two sperms. Okay, this is one sperm and this is one sperm. Okay, now here 23 chromosomes are there, here 23 chromosomes are there, and here 23 chromosomes are there. So 23, 23, 23. Now you will be getting 69 chromosomes. So it's a triploidy state. Instead of diploidy, you are having triploidy. Okay. So that results in 69 XXY. This is the most common karyotype which is seen with the partial mole. Okay. This is the most common karyotype. In 5 to 10% of the cases, you will be having 69 XYY. Why there are two Y's here? Why? Because both the sperms, imagine something like this. If both the sperms are carrying Y chromosomes, okay, for example, here is also Y. Now, then the condition will be 69 XYY. Okay, so most commonly it will be 69 XXY. But in 5 to 10% of the cases, if both the sperms are carrying the Y chromosome, then it will be 69 XYY. This is 5 to 10% of the cases, and this type of karyotype is most common. Now, let me ask you one thing. Here, this partial mole is not too much bad condition. See, I am only comparing. When compared to complete mole, partial mole in the name itself is there. It's a partial thing. So here, the trophoblastic outgrowth is not going to suppress the baby formation, or it's not going to suppress the fetus. So what I want to put into your mind is, here, yes, there is the trophoblastic proliferation is happening, but also fetal development will happen. So you can see the fetal tissue, though the fetal tissue is non-viable, absolutely the baby is going to be dead baby. But you can see a fetus along with the abnormal trophoblast. Okay, abnormal trophoblast. See, trophoblast is the one which forms the placenta, we know. See, here the placenta is definitely not the normal. See, you can see a baby. Okay, you can see a fetal part, not of this much good clarity, but there might be a development of fetal parts also. Okay, not this much clear. Okay, so what I want to put into your mind is, This partial mole is a condition of a triploidy due to a dispermic fertilization. Okay, dispermic fertilization, and fetal tissues are usually present with the partial mole. Why I am saying this? Because when I am discussing complete mole, there we will discuss fetal tissue is not present. The trophoblast is too much growing and it doesn't allow the baby to form. The entire space of the uterus is occupied by the trophoblast in complete mole, so that their fetal tissue is not present. Here in partial mole, fetal tissue is usually present. Okay, so now let's take the important points. Yeah, we have discussed that partial mole is a dispermic. Two sperms are fertilizing a single ovum. And what is the most common karyotype? 69XXY is the most common karyotype. Okay, it's a triploidy condition. Yes, we have seen that. And important point is that, see, instead of 46 chromosomes, here there are 69 chromosomes. So there is extra genetic material, extra chromosomal material. And that extra chromosomal material, from where it's coming? It's coming from the mother, it's coming from the father. It's coming from the father. So extra genetic material is paternal in origin, MCQ. Okay, the extra genetic material is coming from the father. Why? Because two sperms are fertilizing the single ovum, and at the end, fetal tissues are usually present with the partial mole, MCQ, MCQ, MCQ. Okay. Now, having said that, now let's discuss about complete mole. Okay, complete mole. See, why exactly this complete mole is happening? Now, please concentrate, guys. See here, what this one. Okay, whatever you are seeing over here, it's a ovum, and this is your sperm. Okay, sperm and ovum. See, this is something normal. See, sperm is carrying 23 chromosomes, something normal. But here, please concentrate in the ovum. Okay, in the ovum, there is no genetic material, empty genetic material. So, whenever ovum is not having any genetic material, if sperm fertilizes such a ovum, what happens? Now, this 23 is going to enter over here, 23, for example, X, 23X. Now, what happens? So, this genetic material, so this paternal genetic material, it is going to duplicate, okay, and now it will become 46XX. So, now in the end it just looks like a normal, right? In the end it just looks like 46XX. So, this is a diploid state. Yes, complete mole is such a condition where a sperm is going to fertilize an empty ovum without any genetic material. Now this paternal chromosomes, paternal genetic material is going to duplicate. This is known as androgenesis. Okay. Now because of the duplication of the genetic material, you are going to end up with normal diploid condition. It will be 46XX. Okay. This is the most common karyotype, 46XX you are going to have. Okay. Now see, this is complete mole, right? Now, complete mole is a condition which is more dangerous than partial mole. Now, having said that, if it is a dangerous condition, it's not allowing any fetal tissue to grow. Now, as I have already said you, see here in complete mole, the trophoblast is going to proliferate too much. It is occupying the entire uterine cavity. Okay, the entire uterine cavity is going to be filled with this a cyst kind of a material. See, these cysts are nothing but the trophoblastic tissue, and it is totally crowding up the uterine cavity. There is no fetal tissue is growing. See, this is entire trophoblastic tissue. This is the entire trophoblastic tissue which is completely occupying the uterine cavity. Okay. Now, let's see a few important MCQs. Now, this is a condition of monospermy or bispermy or dispermy. This is a condition of a monospermy. Okay, it's a one single chromosome which is fertilizing. Usually, okay, there are certain kinds where there will be dispermy also. That we will discuss in the next slide. But for now, it's a monospermic condition, sperm fertilizing an empty ovum, and you are going to have a diploidy condition, 46XX, which is the most common karyotype which is seen with the complete mole. We have seen that. And there is a duplication of the paternal genetic material is happening. That's known as androgenesis. They can directly ask you, androgenesis is happening in partial mole or complete mole? It's happening in complete mole. Okay. Now, the entire genetic material, guys, here in complete mole, the entire genetic material is paternal in origin. Yes. Why? Because See, the womb is empty. So whatever the genetic material is coming, it's coming from the father. So entire genetic material is a paternal in origin. Okay. Okay. Now let's see that fetal tissue is absent. Yes, we have already seen that fetal tissue is not growing. Now after seeing this, let's talk a few important MCQs regarding the complete mole. Okay. What are they? See, it's such a dangerous condition. Here, because of the too much proliferation of the trophoblast, what happens? There is increased production of beta HCG. See, beta HCG is also increased in partial mole. Why? Because there also trophoblastic proliferation is happening abnormally. But here, there is too much proliferation that increases too much production of beta HCG. So, whenever there is too much amount of beta HCG, there can be symptoms like hyperemesis gravidarum. Okay. Now, let's see. There is increased beta HCG production. True, even in partial mole, guys, remember, even in partial mole, beta HCG is increased, but here markedly increased, so much increased. Okay, so increased beta HCG is seen, and size of the uterus is greater than the period of gestation. Now you can clearly see here that the entire uterine cavity is filled with these vesicles, grape-like vesicles. Now, as it's too much proliferating, the uterine size is more than the period of gestation. Yes, true. Okay. The size of the uterus corresponds to, it's not corresponding to the period of gestation, it's more than the period of gestation. Okay. Now, these vesicles, okay, these fluid filled vesicles, now they will be coming out of the vagina. Okay, so passage of grape like vesicles can be seen. Okay, it's a clinical feature. Now, if a female is saying like, I'm having this prune juice like discharge, I'm having this grape like grape clusters, okay, clusters of grape like discharge. Now you should be thinking about that. It's a complete mole. Okay, grape like discharge, prune juice like discharge is coming out of the vagina. Okay, so yes, this can be seen. Now after that, the risk of pregnancy induced hypertension is very much more with the complete mole. Guys, this is the trophoblastic disease. This is, as I have said, this is trophoblastic disease. Now we all discussed in the pregnancy induced hypertension, the preeclampsia and all. Why preeclampsia is happening? See, preeclampsia is because of abnormal vascular remodeling. Actually, the trophoblast, okay, that cytotrophoblast should go into the maternal spiral arterioles and it have to do the vascular remodeling. That's the function of trophoblast. Here the trophoblast is crazy. Here the trophoblast is madly proliferating. Do you think that this crazy trophoblast will do its normal physiological vascular remodeling? No, it's not going to do. So whenever there is abnormality in vascular remodeling, that causes pregnancy-induced hypertension. We know that. So there is a risk of pregnancy-induced hypertension. Usually pregnancy-induced hypertension or preeclampsia is going to be seen after 20 weeks of period of gestation. But here the pregnancy-induced hypertension will be seen before 20 weeks of period of gestation. Okay, that's something important to be noted. So all these are going to be clinical features of a complete mole. Okay, see, these features can also be seen a little bit in partial mole. In the differences we will discuss that, but these symptoms are markedly seen with the complete mole. Okay, now let's continue. There is an increased risk of a pulmonary embolism. These vesicles can go into the vessels and it can lead to pulmonary embolism. MCQ, pulmonary embolism is a risk seen with molar pregnancy. True. Okay, which gynecological condition is associated, which obstetrical condition is associated with the risk of pulmonary embolism? It is complete mole. Okay, now having said that, let's see what are the risks which are seen with the increased beta HCG levels. Now trophoblast is abnormally getting proliferated. See, which trophoblast is abnormally getting proliferated? Is it syncytial trophoblast or cytotrophoblast? Both. Okay, both of them are abnormally getting proliferated. We know beta HCG is coming from the syncytial trophoblast. So whenever the syncytial trophoblast is abnormally proliferating, there is too much amount of beta HCG production. Now this too much amount of beta HCG, what it is doing? Now actually physiologically beta HCG is the one which is associated with the vomitings and all during normal pregnancy. Now whenever there is too much amount of beta HCG, hyperemesis gravidarum occur. Okay, so hyperemesis gravidarum is seen because of increased beta HCG. Yes, true. Okay, now we all know that beta HCG is having alpha subunit and beta subunit. Now beta subunit is something specific for the beta HCG, and we have already know that alpha subunit of beta HCG is similar to a TSH, thyroid stimulating hormone. So whenever there is too much amount of beta HCG, now the alpha subunit can act like TSH. So it can stimulate the thyroid gland and can lead to hyperthyroidism in this female. So a female with a complete mole is at risk of hyperthyroidism. Now she can be having the features of hyperthyroidism. Yes, true, MCQ. Now this alpha subunit, it's also similar to FSH and LH. So now this alpha subunit can act like FSH and LH, and it can act on the ovaries, and it can lead to bilateral theca luteal cyst. Okay, see, this bilateral theca luteal cyst can be seen in the complete mole, and it can be very rarely seen in partial mole. Okay, so these are some important points about complete mole. Wait, why there is complete mole? Whenever an empty ovum is fertilized by a single sperm. Okay, whenever empty ovum fertilized by single sperm, and the genetic material in the sperm is going to be duplicated, that's androgenesis, that resultant product will be complete mole, abnormal trophoblastic proliferation, entire uterine cavity occupied by these grape-like vesicles, and prune juice discharge will be seen. Now having said that, let's see an image where clearly how complete moles formation is depicted. See, we all know complete moles are diploid. Yes, 46 chromosomes are going to be there. How usually it happens? Empty ovum, there is no chromosomal material. Empty ovum is fertilized by the single sperm, we know that. Okay, 46XX. But in 5 to 10% of the cases, this empty ovum, okay, empty ovum are fertilized by two sperms only in very few cases. Okay, now if it is fertilized by two sperms, something like, you might be thinking, sir, this is a condition which is similar to partial mole. No, partial mole, there you are having it's a triploid condition where the ovum is having genetic material. But this is a complete mole where the ovum is having no genetic material. Now it's getting fertilized by two sperms very rarely. Like, you know, now see here, 23, 23. So 46 will be there. If both the sperms are XX, it will be XX. If one sperm is X and one sperm is Y, it will be XY. So this type is usually seen with 5 to 10% of the cases. But most common is 46XX karyotype. Okay. Now, having said that, now let's discuss what are the risk factors. Okay. In which females are most likely to have this kind of a molar pregnancy. Okay. Both complete mole as well as partial mole. See, age. Okay, so extremes of ages. Okay, extremes of ages less than 20 years of age. Okay, that's a teen pregnancy, and more than 35 years of age. So extremes of age are risk factor for molar pregnancy. Previous history of molar pregnancy is a risk factor. And vitamin A deficiency, this is the MCQ. Vitamin A deficiency is the risk factor for which obstetrical condition? Molar pregnancy. Okay, vitamin A deficiency. And Asian population, okay, this molar pregnancy is having highest incidence in Philippines. Okay, so Asian population, which country is having highest incidence? Philippines. Okay, Philippines is having highest incidence. Asian population is a risk factor. And having AB blood group. Okay, having AB blood group followed by A blood group. Having AB blood group is a risk factor for molar pregnancy. And previous spontaneous abortion, twice the risk of molar pregnancy. Previous spontaneous abortion is a risk factor for developing molar pregnancies. Guys, very, very important. Out of these, AB blood grouping, important risk factor for molar pregnancy, and vitamin A deficiency, important risk factor for molar pregnancy. Okay, so these are the risk factors. Now, let's see what are the differences between a partial mole and, like, you know, complete mole. Most, like, you know, almost 80% of the differences you already know. Okay, there is no doubt you know them. See, without any, like, you know, I just don't, like, you know, don't want to simply spend the time. Let's directly jump to the answers. See, karyotype. See, partial moles, they are triploid in nature. Like, you know, it's a dispermic, right? Two sperms are fertilizing a single ovum. So usually triploid, and most common karyotype is, here typing mistake is there. Let me write it here. It is 69XXY. Okay, 69XXY is the most common karyotype. And complete moles are diploid. You already know that. Okay, diploid, and the most common karyotype is 46XX, and some cases, 5 to 10% of the cases, it will be 46XY. Okay, so it is monospermic. Okay, complete mole is a monospermic condition where the duplication of genetic material is happening. So fetal parts or fetal tissue in partial mole, yes, fetal tissue is present, I have shown you. And in complete mole, there is no fetal tissue is present. Okay, now let's talk about the trophoblastic proliferation, where trophoblast is aggressively proliferating, too much proliferating, diffusely proliferating. Yes, in complete mole, there is a diffuse proliferation of the trophoblast and entirely occupying the uterine cavity with grape-like vesicles. And here in partial mole, there is just only focal, not too much, okay, focal proliferation of the trophoblast is seen. Now, let's talk about the histological findings. If you look at the histology, this is what you don't know, okay, if you look at the histology, in partial mole, see partial for present, P for P, in partial mole, these kind of histological features are seen, trophoblastic scalloping and inclusion bodies. These are histological features. Okay, these are histological features. Both the histological features are present. Okay, trophoblastic scalloping and inclusion bodies are seen with the partial mole. They are not seen with the complete mole. Okay, they are not seen with the complete mole. Now, if you do the ultrasonography, okay, usually the investigation of choice, okay, the investigation of choice for the molar pregnancy is a transvaginal sonography. Okay, ultrasonography transvaginally. Okay, so it's a transvaginal ultrasonography is the investigation of a choice. Remember this point, it's a MCQ. Now, if you look at the partial mole, now it looks like a missed abortion. Okay, why? Because there is some fetal tissue is present, okay, fetus is present, and it's not appropriate to the period of gestation, it's not growing, it just looks like a missed abortion. Okay, so on ultrasonography, it just looks like a missed abortion. But if you look at the complete mole, now complete mole, it shows a snow storming appearance. Okay, snow storming appearance is seen with the complete mole. In the next slide, I will also be showing you the image, how it actually looks. See, snow storming appearance, and also there is one more name for that. It is honeycombing appearance. Okay, honeycomb. Okay, honeycombing appearance or snow storming appearance on ultrasonography is seen with the complete mole. Okay, very important MCQ. Now, let's talk about the uterine size. See, uterine size is very much more than the period of gestation in complete mole. Okay, size of the uterus is more than the period of gestation in complete mole. Here, the size of the uterus is lesser than the period of gestation. Okay, why? Because there is some fetal tissue, it just looks like a missed abortion. The fetus is not growing, only the trophoblast is proliferating focally. So, size is less than the period of gestation. Beta HCG level in both the condition, partial mole as well as the complete mole, in both the conditions, beta HCG levels are elevated, but in complete mole, there is a marked rise in beta HCG levels, more than 10 to the power of 5 international units. Okay, more than 10 to the power of 5 or more than 1 lakh international units is seen with the complete mole. Here also, beta HCG levels are elevated, but not greater than 10 to the power of 5 international units. Now, let's see the thecal luteal cyst. Yes, we have seen because of the increased beta HCG, thecal luteal cyst can happen. Now, these thecal luteal cysts, these are rare. Okay, thecal luteal cysts are rare with the partial mole. Thecal luteal cysts are usually seen with the complete mole. Okay, they are very much common with the complete mole. Now, post-molar malignant sequel. Post-molar malignant sequel means, see, now this molar pregnancy, either it is partial mole or complete mole, both of these conditions are benign conditions, no doubt. But they are having malignant potential, which means they can turn into gestational trophoblastic neoplasias. Yes, they can turn into cancers. Now, out of both these conditions, who is more dangerous? Yes, complete mole is more dangerous. So, there is 20% chance that this complete mole can turn into gestational trophoblastic neoplasia, and complete mole, there is less than 5% chance that they can turn into gestational trophoblastic neoplasias. Okay. Now, let's talk about the immunostaining or P57 Kep2 staining. See, this P57 Kep2 staining will only be positive if there is a maternal genetic material. Now, this Kep2 staining is not going to be positive whenever there is no maternal genetic material is present. So, in partial mole and complete mole, let's see the difference. Complete mole is a condition where the entire genetic material is paternal in origin, so that there is no maternal genetic material. If there is no maternal genetic material, automatically this P57 Kep2 is going to be negative. There is no maternal genetic material. Okay, no maternal genetic material. So the stain is going to be negative. In partial mole, the extra genetic material is paternal in origin. There is also maternal genetic material. So here the Kep2, P57 Kep2 stain is going to be positive MCQ. Okay, now let's see how the snowstorming appearance looks like. See, these are the grape-like vesicles, trophoblastic tissue which is abnormally getting proliferated in complete mole. So it will looks like a snowstorming appearance or honeycombing appearance on transvaginal ultrasonography. If you do TVS, snowstorming or honeycombing appearance, you will be seen in complete mole. Okay, complete mole is also known as hydatidiform mole. Okay, just I want you to know that complete mole is also known as hydatidiform mole. Now let's talk about the management. Yes, okay sir, there is complete mole or partial mole, doesn't matter. What is the management? The management is one and the same. It's a suction evacuation. Take out the trophoblastic tissue. Suction evacuation. By suction, evacuate the uterus. Take out all the trophoblastic tissue. Okay, for both partial and complete mole, these are benign conditions. Simple suction evacuation and take out the tissue, send it for the histopathological examination to confirm that there is no cancer happening. Okay, and the tissue whatever you have taken out, these tissue, trophoblastic tissue needs to be sent to the histopathological examination. Management is suction evacuation. Now see, there is one condition where you are going to do the hysterectomy. In which condition, sir? See, it's a complete mole. There is a lot of chance that it can turn into cancer. So complete mole. Now the female's age is more than 40 years and her family is completed. Okay, complete mole, if they mention complete mole with the family completed, the family of the female is completed and her age is more than 40 years. Now in this condition, now you are going to choose the hysterectomy. Okay, hysterectomy. Okay sir, well and good. Now what is the management for the thecal luteal cyst? Now these are thecal luteal cysts, you don't need to do anything. Just after suction evacuation, automatically these thecal luteal cysts are going to be automatically going to be resolved. Okay, so this thecal luteal cyst will be regressed. Okay, so thecal luteal cyst, there is no treatment required. MCQ. So thecal luteal cyst doesn't require any treatment modality. Okay, no need of any drugs. Okay, they will be automatically regressed once you do the suction evacuation properly. Okay, now after this, let's talk about the follow-up. Okay, you have done the suction evacuation. Are you going to just leave this patient? No, we know this complete mole and partial mole, they are having a certain capability for turning into cancers. So what you have to do, you have to be you have to be very much cautious and you have to ask the patient to regularly come up for the follow-up. So follow-up is going to be done after suction evacuation. Follow-up is going to be done till 6 months. Okay, till 6 months you are going to do the follow-up by measuring the beta HCG levels. Okay, so if everything is going to be all right, if you have done the suction evacuation properly, you have taken out the entire trophoblastic tissue, what actually happened? Beta HCG levels should be gradually falling down. Okay, so every day by day, the beta HCG levels should be coming down. So if beta HCG levels are coming down, that's something what we need. Okay, that's something normal. If beta HCG levels are coming down, everything is getting settled down. But if beta HCG levels are not coming down, okay, they are maintaining, which means still the trophoblastic tissue is present inside the uterus. So you have to do the suction evacuation and you have to ask the patients to come up for the follow-up for the next 6 months. And for the follow-up, what you are measuring? You are measuring the beta HCG levels, MCQ. Okay, now let me ask you one question. See, these beta HCG levels are going to come back to normal after how many days? See, if it's a partial mole, okay, if it's a partial mole, beta HCG levels are going to come to normal by 7 weeks. If it's a complete mole, it takes 9 weeks for the beta HCG levels to come back to normal. So follow-up should be done till 6 months, and this beta HCG levels, see, if it's a partial mole, beta HCG levels will come back to normal by 7 weeks. In a complete mole, it takes 9 months for the beta HCG to come back to normal level. Okay, and the follow-up should be done till 6 months. Okay, don't say by 7 weeks, this is the condition of partial mole. After suction evacuation, 7 weeks, the beta HCG levels are going to come back to normal. I'm not going to do the follow-up. Don't say like that. Okay, even after 7 weeks, even if the beta HCG levels are normal, you have to do the follow-up. Okay, now after this, let's talk about some important points. See, pregnancy is contraindicated. After this molar pregnancy is contraindicated till how many months? Till 6 months, the pregnancy is contraindicated. Why, sir? Why? Because within this 6 months, if she gets pregnancy, beta hCG levels will be starting elevated up. So you don't know, you can't differentiate why the beta hCG levels are elevating. See, beta hCG levels might be elevating because of, again, trophoblastic tissue is growing. Okay, so you can't differentiate whether the increase in beta hCG levels are because of pregnancy or this again molar pregnancy is happening. So pregnancy is contraindicated in the next 6 months after section evacuation. Okay, and contraceptive of choice is going to be oral contraceptive pills, MCQ. This is also MCQ. Okay, now at the end, let's talk about the prophylactic chemotherapy. Prophylactically, this is prophylactic. Okay, so prophylactically you are giving drugs. When you will be giving prophylactic chemotherapy? In all the conditions, in partial mole? No, in complete mole, wherever there are high risk factors. Okay, it's a complete mole condition where there is a high risk that this complete mole may turn into gestational trophoblastic neoplasia. If you suspect that, then you will be giving the prophylactic chemotherapy, preventing the gestational trophoblastic neoplasias. See, in which conditions you will be giving the prophylactic chemotherapy? In a complete mole condition where the beta hCG levels are more than 10 to the power of 5 international units, the uterine size is more than period of gestation, thecal luteal cyst more than 6 centimeters in size, and the age of patient is more than 60 years. If the age of 40 years. If the age of the patient is more than 40 years. Now, a complete mole patient associated with these conditions, then you will be giving prophylactic chemotherapy, and the agent and the drug that you will be using for prophylactic chemotherapy is a methotrexate. Okay, or in the resistant cases you can use actinomycin D. Okay, actinomycin D, it's in resistant cases, but methotrexate is the prophylactic chemotherapy agent of choice for high risk cases of complete mole. Okay, after suction evacuation you are going to give the prophylactic chemotherapy. Guys, we have completed the molar pregnancy. In the next video, let's discuss about gestational trophoblastic neoplasias. Hope the video is helpful. Thank you.